and welcome to this Living Well webinar looking at issues for younger patients. Often when we talk about younger patients, we generally mean those under about 50. But of course there are patients who are fit and well in their 60s who would say that they were considered younger patients, and certainly that is often the case. There are patients in their 65 and even up to 70 who are fit and well enough for a stem cell transplant, for instance. So we know that myeloma is usually diagnosed in older patients, in older people. Statistics from between 2010 and 2012 show an average of 43% of cases were diagnosed in people aged 75 and over. The statistics for younger patients show that 5% are younger than 50 and just over 1% are younger than 40. The statistics we use are taken from a range of resources, including Cancer Research UK. This graph from Cancer Research UK shows the age-specific incident rate. For this webinar, we'll look at issues which specifically affect younger patients, such as fertility, talking to children, work and finances, a type of transplant used only in younger patients, and specific emotional support. This is a really big topic which I really won't be able to do full justice to in the time we have today, but I will try to cover as many issues and answer as many questions as I can, and I hope you find it helpful. So first of all, I want to talk a little bit about fertility issues for those diagnosed with myeloma. These won't affect everyone, of course, but it is a topic we get asked about from time to time. We know that myeloma treatments, particularly the chemotherapies such as cyclophosphamide and malphilan, are known to have an effect on fertility in both women and men. However, the effect on fertility from treatments such as Velcade is still fairly uncertain. We will also look at what is available to preserve fertility and contraception. We know that in general, women are waiting longer to have babies than in previous decades. This means that fertility issues are becoming more evident if a patient is diagnosed in their 30s and 40s. Treatment for myeloma affects fertility in a number of ways. It can have a detrimental effect on hormone levels, have a direct effect on the function of the ovaries, and their ability to produce eggs, and it can cause an early menopause and change the lining of the uterus. In men, some treatments can affect the production of sperm and testosterone. It can also have a negative effect on sex drive, and there may be some erectile dysfunction issues. Bearing in mind that this can also be caused by the psychological impact of the diagnosis of myeloma. There are ways that fertility can be preserved. If having a baby is something that is planned, then do ask about freezing and storing eggs or sperm. Unfortunately, female methods of preserving fertility can be time-consuming and can be invasive. So perhaps the urgency of starting myeloma treatment means that's not possible. Of course, this would very much depend on the individual situation. However, sperm banking is something that is widely available, and it's much easier to do. It is advisable not to get pregnant or get a woman pregnant while having myeloma treatment, as there can be damage to the baby's development. This is particularly true with the thalidomide, lenalidomide and pomalidomide. These drugs are prescribed using quite strict risk management programs to ensure that no babies are born with the deformities that we saw when thalidomide was used as a treatment in the 50s and the 60s. Moving on from problems with fertility to the issues many younger patients face when talking to children. We often get asked on the info line what is the best way to talk to children about the diagnosis. it can be an extremely anxious time, and sometimes patients do put it off. However, the longer you leave it, the harder it will get. It's often best to decide a time and a place to do it and do it. There are many ways you can be there for children, and they are often more astute than we give them credit for, and they may well sense that something is going on. Sometimes it's best to give a bit of a warning shot and sit down and do something that you would do ordinarily. That can often take the stress out of the situation. And make sure that everyone is involved, mum, dad, and even other family members if they want to be. If auntie wants to be involved, then please do welcome along. Just make sure that everybody's saying the same thing, and that children are kept up to date so that they don't feel excluded, and that everybody's speaking about the same thing. It's important to focus on what's important, and it's difficult talking to older children, perhaps more so than it is younger children, teenagers. We know that it's difficult talking to teenagers at the best of time. We do have some resources for younger children. We have a booklet called Kelsey and the Yellow Kite, which is written about about a young child, Kelsey, about her dad's experiences. And we were told by a patient recently that they had this booklet, they put it down on the coffee table, and when the child showed an interest in the book, that's when they sat down, read the booklet to them, and started talking about their own situation. We also have, it's also helpful sometimes to speak to others who may be in similar situations. Support groups are often very good. Online discussion forums. We have a peer network. Our peer network is a database of patients and families who've said they're happy to talk to others on the phone and share their experiences. And there are peer members who are younger and who have young families. So if that's something that you think might be helpful, then do let us know. I want to talk now a little bit more about the issues faced by those who are working. Some patients do choose to continue to work, and it helps them to maintain a sense of normality, stability, and maybe necessary for financial reasons. Work is also often an important part of someone's identity. However, it's not always possible to continue to work, depending on the patient's physical well-being, the nature of the work, the treatment, and the level of side effects experienced. And it can have a massive impact on feelings of self-esteem and well-being. So work is an issue for everybody differently, but it's something that we talk about quite regularly on the infoline, for instance. It's a good idea to talk to your employer, either your occupational health advisor or the HR department. Although you don't have to tell them that you have myeloma. But if your myeloma or its treatment affects your ability to do your job, this could cause problems later on. Patients often worry that they will be sacked or made redundant, but it's worth bearing in mind that all cancers are classified as a disability, and there is the Equality Act which protects them. So do bear that in mind. These are the two acts that ensure employers make reasonable adjustments that can help support patients in their workplace, and specifies that employers cannot treat those with myeloma less favourably than another employee. And reasonable adjustments should be made, if at all possible, to help patients to continue to work. It may mean changing hours or shifts or the type of work done. And this, if possible, can be done without causing too much disruption. Reasonable adjustments will also include allowing time off for hospital appointments. Again, it depends where the patient is in their treatment pathway, how much or how regularly they will need time off. For instance, patients receiving treatment in tablet form may not need as much time for hospital appointments as those who are receiving it by injection. For instance, patients who are on Velcade, which is given in the form of an injection, would have to travel to their hospital on a weekly or twice weekly basis to receive that. It is important to be aware of your employer's sick leave policy and the other policies that they have in place around your working. Again, it's coping with the symptoms and side effects of treatment whilst working. It's important to be honest and open if you can be. If you're on a treatment that's causing you some problems, do let someone know. There will be times, of course, when your immune system is particularly low. Both myeloma and the treatment for it can cause your immune system to be low, and you will be immunocompromised. So you may need to take particular care, for instance, if you're working in a busy area where there are lots of people around. And again, common sense issues, common sense plays a role here. Avoid anyone with obvious signs of coughs and colds. And myeloma and some of its treatments can cause changes in appearance, so perhaps be a bit prepared for that. We know that many patients do lose some height. Some patients do have a bit of a curvature of their spine. Weight loss can happen if you're on treatment that's affecting your appetite. There wouldn't be hair loss unless you're going for the high dose therapy and stem cell transplant. That's when patients experience hair loss. Really, some other treatments do perhaps cause some thinning. And don't be shy to ask for help, speak to people, and you may well be surprised at some of their reactions. So there are a number of benefits which patients may be able to claim. I always say that the best person to talk to is someone from the social work department at the clinic you attend. You should be able to make an appointment to see someone and sit down and talk about your individual situation. They can also help with filling out the very complicated forms. I know these forms are really very complicated, and I would always advise someone not to try and fill it out on your own. Get some help from someone who knows what they're doing, who's used to filling out these forms, and who knows what wording to use. But remember, if you do get a negative decision about any benefit claim, you can always appeal that decision. There are things are changing since the budget from last year. Things are changing with benefits, as you've probably heard about all over the media. So the Citizens Advice Bureau, someone from the social work department, a Macmillan nurse whose expertise is finances and benefits will be able to tell you the latest litigation, what's available, and looking at your individual cases. We do have an information sheet specifically on finances, which you might find helpful. Now we're looking at a type of stem cell transplant that is really only used for those who are deemed to be younger and fitter. As we've said, we know myeloma is usually diagnosed in older people, but younger, fitter patients are perhaps suitable for a different type of stem cell transplant. High dose therapy and stem cell transplantation using the patient's own stem cells is routine in myeloma for those up to about 65. But again, there are patients over 65 who are deemed fit and well enough to have that type of transplant. But there are a small number of younger patients who may be considered for a donor or allogeneic stem cell transplant if a matched donor is available. There are two slightly different versions of this type of transplant. A full intensity one for very young patients, about 40 to 45 or younger, which uses very high doses of chemotherapy and total body radiation. And the mini or reduced intensity transplant, which doesn't use total body radiation and uses lower doses of chemotherapy. Of course, the better the match, the less the risk of complications from this type of transplant, and that's why patients' siblings are asked if they're a match. And there's a better chance of them being a match. So the allogeneic stem cell transplant does carry a greater risk than the transplant using the patient's own stem cells. But it also has the potential to produce a prolonged period of plateau or remission. As you can see on this slide here, there are potential advantages and disadvantages. The advantages being that the stem cells from the donor recognise any residual myeloma cells as foreign and destroys them. That's called graft versus myeloma effect. Disadvantages may be that the donor cells not only recognise myeloma cells as foreign and destroy them, but also recognises patients' own healthy cells as foreign. And this is called graft versus host disease, and this is the big risk of an allogeneic or a donor stem cell transplant. Graft versus host disease can be either acute or chronic. Acute means that it's quite severe and it comes on fairly quickly, and chronic means that it's perhaps less severe and lasts for a longer period of time. It's certainly worth speaking to your haematologist if you're keen to think about this type of transplant as an option for you. Speak to other patients too. There's a Facebook page I know where often younger patients post quite regularly on that, share experiences. Again, the discussion forum on our website has an under 50 section, and one of our peer members from our peer programme may well be able to talk to you about this type of transplant as well. So looking at now at emotional support for younger patients. We know, all myeloma patients need emotional support, but younger patients may require different support and information due to the stage in their life, their work commitments, the young families that they have to support, any financial commitments, and living day to day with a cancer that generally affects much older people. I was speaking to someone on the Infoline just recently who attended a support group, and she did feel somewhat out of place in a room full of people over 60, over 70, but she soon realised that the sharing experiences was invaluable, and the support group actually was very, very useful, and she continues to attend on a regular basis. There are other organisations such as Maggie's Centres, Cancer Information Centres. Macmillan is very good. So there's lots of resources and support out there for you. So in summary, myeloma, we know, affects generally people over 65, but it does also affect younger patients too, and they do have somewhat different challenges, different issues to face around fertility, around work, around talking to children. So I hope that's been able to cover those issues for you, and I'm happy to try and answer any questions that you have, bearing in mind that I can't see you or your medical notes, so the answers that I give will be quite general.
So we will just jump straight in, I think, Helen, if you're ready.
Yeah, absolutely.
And we'll just pull up the first question. So this first question is from Helen, who asks, I have smouldering myeloma and I'm only 50. Is counselling available, as I really struggle getting my head around it all, and my GP and consultant just see me every 3 months. They say things are good but don't have time to chat things through. Who would I contact to try and get some help?
That's a good question, Helen, and it's something that we come across every day actually. For patients who are diagnosed with smouldering or asymptomatic myeloma, it's like a pre-myeloma where myeloma has certainly been diagnosed, but it's not at this point causing any problems with the bones, with the kidneys, with the immune system. So for patients diagnosed with this particular type of myeloma, a watch and wait scenario is what takes place, and patients are monitored regularly. But it is it does have huge psychological and emotional issues. Patients say that they feel as if they're living on a knife edge from appointment to appointment and wondering when it's going to actually turn into active myeloma and treatment is needed. So yes, it's a huge psychological problem. I think that if there's a nurse specialist at the clinic that you attend, I know that the doctors and nurses are always really busy at the clinics, but sometimes the nurses have a wee bit more time. And if you want to make an appointment with the nurse specialist, first of all, ask who your nurse specialist is, get a name, get a phone number, and maybe make an appointment where you can sit down and talk to them without them being interrupted by buzzers and bells and things like that. So do speak to the nurse specialist perhaps in the first instance. Again, there's support online, discussion forums, there's support groups, support groups welcome patients, family members, friends, myeloma, smouldering myeloma, so do see perhaps if there's a support group in your area. And yeah, give me a call on the info line. I'm happy to try and clarify anything you're not sure of, answer any questions that you have, to give you a bit of support that way. But I think what is important is that you don't suffer in silence. It's really, we do recognise that it is quite an emotional time.
Okay, thanks Helen for that answer. The next question is from Nicola, who asks, as a 54-year-old, what is the best way to get involved in trials?
Okay. Thanks for that, Nicola. Yeah, there are quite a few trials available, and if you've had a look on our website, we have a myeloma trial finder section, so you can see what trials are available in the UK. As I say, there are quite a few. You can define it by stage, so if you're newly diagnosed or if you're relapsing, you can have a look at those trials that are available for you. I think the best way to get involved in trials is to speak to your haematologist. Your haematologist should know what trials are available in your area and will be able to tell you if you're a suitable candidate for that trial. Every trial has quite strict entry exclusion and inclusion criteria, so if you fit that criteria, then your haematologist will be able to say if that's a suitable trial for you.
Okay. The next question is from Jules, who says, I was diagnosed 4 years ago, aged 41. My daughter was 4 and we didn't tell her about my diagnosis. She's now nearly 8 years old and we feel she's old enough to understand. How do we tell her about my myeloma?
Gosh, Jules, that's a good question, and the fact that she hasn't known for the past 4 years, you've obviously done a very good job at getting on day to day with your life without. But she may well have picked up some clues. She may well have sensed that something is going on. So, and as I said previously, sometimes a child's imagination is worse than the actual reality. So, yeah, I think it's a good idea now to sit down and speak to her. As I said before, maybe give her a bit of a warning shot when you're about to do something that you would ordinarily do. If you're used to sitting down in the evening to your main meal of an evening, perhaps say, Mummy and Daddy want to speak to you about why Mum has been attending hospital on a regular basis. So give a bit of a warning shot, let her know that you're going to have a bit of a serious conversation, and that will, prepare her for what's to come. And then, put it in simple language, simple terms, allow her to ask questions. She will now feel that she's going to be included, and say that, there's nothing wrong with saying we'll let you know how things are going, we'll tell you how we get on at the hospital. And yeah, if you want to involve other family members, do that as well. There is also counsellors available, and family counsellors particularly. So if you feel that that's something that would be helpful, Jules, then ask at the clinic you attend, ask if there's a counsellor who can sit down with you and the whole family, just to broach the subject, just to allow your daughter to ask questions and get her anxieties out. But I think you'll find that once you're over that initial really hard bit, it should get easier after that, but give her time. It will be a bit of a shock initially, no doubt.
Thanks, Helen. Okay, the next question's from Sophie, who asks, how can I meet other patients my age? All the other patients I've met so far are lovely, but much older than me.
You sound like the lady I was talking about earlier, Sophie, who attended a support group to find it was attended by those in their 60s and their 70s and even in their 80s. But as I say, once she'd settled into it and realised that the experiences were very similar and was able to take a more active part in the support group, she really enjoyed it. But for finding someone who's more nearer your age, there may well be other support groups. I mean, do have a look. You can see on our website, we have a page, we have a map of support groups in your area. We have an information sheet about it. So first of all, see if there is a support group in your area. There may well be younger patients attending there. And things like Maggie's centres often have group meetings as well. It doesn't, myeloma specific groups, as you can probably imagine, are fairly thin on the ground. So there may be general haematology groups or general cancer groups that have similar issues. So do find out about that. And as I say, we have a discussion forum on our website, and one of the forums is an under 50s forum. So have a look on there and introduce yourself. And I know also that sometimes younger patients use Facebook perhaps or some of the other online media sites more regularly than older people do. And I know there's a lovely support group page on Facebook that's really busy. Lots of people are sharing experiences about a whole range of topics, from benefits through to talking to children, through to how to prepare for stem cell transplants, for instance. So there's a whole range of topics covered there. So maybe have a look at that as well. And give me a wee call on the info line. I'm happy to talk to you on the phone. So if there's anything you want to talk about more, then I'm happy to do that.
Okay, thank you. The next question is from Chris, who asks, does melphalan affect male fertility, and if so, is it by lowering count or is it from higher risk of congenital abnormalities? There's a follow-up question also about are the effects reversible, and if so, after how long?
Okay. Melphalan certainly it does, especially the higher doses of melphalan that are used for the stem cell transplant, and it does lower sperm count. It may well cause problems with the baby's development, so that's why you would always be recommended to use contraception whilst on melphalan. But yes, to have an effect on fertility, it lowers testosterone and sperm count, and of course men need testosterone to maintain a sex drive and for their sperm count as well. I think generally speaking, for using when they're using very high doses of melphalan, such as when a stem cell transplant is being done, then it would be a permanent effect. It can be temporary. It can sometimes take some while for the sperm count to improve and for testosterone levels to improve, so it can be temporary. It really is very individual, but I think to err on the side of caution, if you were planning to have a family and you were heading for chemotherapy treatment, especially the high dose chemotherapy, you may well be introduced to a family counsellor and be given the opportunity to talk about freezing and storing sperm, because it can be permanent, but it can also be temporary. So do speak to your nurse specialist if this is something that's an issue for you, Chris. Okay,
the next one is from Stuart, who asks, I'm a fit 36-year-old man and I play a lot of sports, football, rugby, etc. Should I remain very active or will that risk injury?
Okay, yeah, so certainly we wouldn't be suggesting that anyone wraps themselves up in cotton wool. It is a bit of a balance to be had between getting on with your life as normally as you possibly can and being quite careful about not injuring yourself. It really would depend very much on how much the myeloma has caused damage to your bones, Stuart. So if you've had some bone damage caused by the myeloma, then yes, you may be advised to step back a wee bit from the intense sports. If you've not had any bone damage, and it does happen, as we know, myeloma is very individual. So if you haven't had any bone damage, if you're on treatment for your myeloma, you will be on a drug to protect your bones. So, whilst your haematologist might turn a bit pale at the thought of you playing full contact rugby, I think have a full and frank discussion with them. How badly are your bone damage? Can you continue with your sports? Things, it may be time to look at doing something else, running, swimming, other forms of sport which would be acceptable and reasonable in someone who's got a degree of bone damage. But it is very much down to your individual, the complications that your myeloma has caused, Stuart. But we do encourage, sport and exercise has many, many benefits. So we would never say, give up sport completely, because it not only helps your psychological feelings of well-being, but it can, remaining very active and keeping up with regular exercise can help to keep your muscles toned, which will obviously support your bones. So there's a lot to be said for maintaining regular exercise. However, if you've got any bone damage, then full contact rugby may not be the best at this stage. Things may well improve as you go along. Often bones do repair themselves to some extent. They will never be at the density they were before you were ever diagnosed, but as the myeloma is brought under control and time goes on, bone density can improve somewhat.
Okay, thanks for that, Helen. Now we've got 3 work-related questions here, which are all a bit different, but they're a bit similar as well. So I'll maybe ask the first 2 questions together,
okay,
and then we'll see if there's 2 different answers. So this is from Matthew, who says he was diagnosed at 38 and is now 41. His work were initially supportive, but then tried to get rid of him. He's now on income protection with them and various benefits, but unable to work because of side effects. He feels trapped by the work situation and scared of losing benefits, as financially he wouldn't be able to cope. Should he just ask to be made redundant and try something else? And I'll just jump onto this one from Juliet as well, who sort of asked, can an employer force you into medical retirement if your treatment is causing numerous absences from work? So although you're doing the job, there's a lot of absence which is becoming an issue. She's aware of DDA, but it really only provides for reasonable adjustment. So I'll jump back to Matthew's one, but I thought it's worth having them both.
Yeah, that sounds like a dreadful situation you're in, Matthew. I think you really need to seek, both you and, was it Julia?
Yes,
you both need to seek advice from various sources. As I say, there should be someone that you can talk to from the social work department at the hospital you attend. Ask your nurse specialist or your haematologist for an appointment to sit down and talk to someone from the social work department. It may be that it's a Macmillan nurse who has a specific expertise in this area, so do ask about that. I also know that citizens' advice are very good at knowing about legislation and what you're entitled to and what your next move can be. So if there's a citizens' advice bureau near you, it might be an idea to make an appointment and speak to them. It is something that does have specific expertise. So I would certainly say, speak to HR, perhaps even at your work, someone from occupational health. Make sure that you take stringent notes about times and places and dates that you met people and what's being said, and have someone with you at those meetings as well, because you can often leave those meetings and forget what's been said. So take someone with you and speak to others, I would say, certainly.
And is there anything else for Juliet there?
Well, we've said that the act that I mentioned in the earlier slide says that your work should provide for reasonable adjustments, and it will have they will have their own policy around this, and will have their own how many times you're entitled to go for hospital appointments. So do have a good look at the policy, ask to see that, take someone with you. And again, I think citizens' advice or someone from the social work department may well be able to help you here, Julia. I really hope they do. And yes, call Macmillan as well. They often have campaigns on the financial aspect of living day to day with cancer. So they have quite a bit of expertise there as well. And again, ask for our information sheets specifically on it. I can pop them out to you. So do let us know.
Okay, thanks. Just got a couple of more questions in, so we'll take them. So this is another work-related question from Justin, who says that he was diagnosed last year and has managed to keep working, but is now struggling, and treatment has left him feeling exhausted. He hasn't told his boss yet and is worried about what he'll say, especially as he didn't say about it straight away.
Well, don't worry about what you haven't done, Justin. I think now is the time to perhaps sit down and speak to someone. If there's someone from HR at your work, an occupational health advisor at your work, perhaps speak to them in the first instance. But I think once you've told your boss and once it's out, I think it might be easier after that. Unfortunately, the way things go with myeloma is fatigue and exhaustion are quite common symptoms of the myeloma and side effects of treatment. So fatigue is probably one of the big issues and one of the many reasons that patients do have time off work. So, obviously your boss may well get an inkling that something is wrong and may well be relieved to sit down and talk to you. Obviously your work situation better than I do and how well you get on with your boss, but it might be an idea to have someone there with you on your side. So and again, speak to the social work department at your hospital or a nurse specialist just to get some tips. They will have dealt with this sort of thing before, I have no doubt, and may well be able to share those experiences with you.
Okay, thanks. And the next question is from Nathan, who says, I'm 28 and was diagnosed 7 months ago with asymptomatic myeloma. This has been categorised as high risk, and as such an allogenic stem cell transplant has been mentioned for the future. I have one sibling. If they're not a match, are registers used such as Anthony Nolan?
They certainly are, Nathan. Yes, Anthony Nolan is the bone marrow registry that's often used to try and find out if there is a match. As I said earlier, it is best if you can get a sibling match, because the chances of them being a close match are better, and that would mean that there was perhaps less risk of complications. But Anthony Nolan, if your haematologist feels that a donor transplant is an appropriate and suitable option for you, and your one sibling doesn't match, then yes, they will ask Anthony Nolan to do a search to find as close a match as possible. Yeah.
Okay, and I think this could be the last question, or possibly one more after this, which is from Sarah, who asks, I am a 38-year-old woman and recovering from high-dose therapy and stem cell transplant. I didn't harvest any eggs before the treatment, as my doctors advised me not to delay. Although we have one daughter, we would like another child. Is there any way I can find if and how my fertility has been affected?
They will be able to tell. Yes, there are hormones that you produce that say how fertile you are, and there are specialist fertility healthcare professionals that you could perhaps speak to. High dose therapy and stem cell transplant does use, as the name suggests, very high doses of chemotherapy, and that's what will have the biggest impact on your fertility. And again, it may be permanent, but it may be temporary. If it's going to be temporary, then usually your fertility would improve within a few years. It can take a few years for that to improve if it is going to be temporary. If it has been permanent, or if you've gone through the menopause, and that can happen early with myeloma treatments, then then it wouldn't be possible, and you may want to explore other ways like adoption, or other ways to have a child. But do ask to speak to a fertility specialist. As I say, they can tell just what hormones you're producing, just to tell how your fertility is improving, if at all. So do ask about that. And the thing is, doctors and nurses are used to being asked these questions. I know it's quite a sensitive issue, and people kind of balk a wee bit at asking these sorts of questions, but it is something that they deal with quite regularly. So please don't worry about speaking to your nurse specialist or your doctor about these sensitive issues. And I would like to think that they will take the time to sit down with you and perhaps refer you to someone else, or to reassure you that some tests can be done and let you know what those are.
Okay, thanks, Ellen. So I think that's all the questions that we've had in, and thank you for answering them. I thought you did a great job. Some very difficult questions.
Thank you.
So,
you were, yes.
Well done. And I think it would be a good idea to just sort of say, if you've asked a question, or if you haven't asked a question but you'd like to speak to someone about anything from this webinar or anything else to do with myeloma, then please do call the myeloma info line. Ellen and Jill and the rest of the team man the info line and can speak to you and give you a fuller and more longer answer to any questions that you might have. So please do that, and if you don't want to call, then you can drop an email to askthenurse@myeloma.org.uk as well, and the team can get back to you on that. Ellen's mentioned several resources throughout the presentation, and they're all available on our website that you can download, or you can order copies of them, printed copies. And I've just pulled up the web page here with our publication list on it. So there's a whole range of topics here, not just ones that affect younger patients, but on everything to do with myeloma. And there's even Myeloma Matters, which is our quarterly magazine that you can download as well. So please do use that as a resource to get more information. And of course, there's also our future webinars, which I just wanted to flag up, that we have myeloma and cognition, caring for someone with myeloma, and recovering from a stem cell transplant. If any of those are of interest to you, then you can register now. Just get your registration in, and when the time comes for the webinar, you'll automatically receive an email to remind you of the webinar. So that's it for today. Thank you very much for joining us. I hope that's been useful, and I hope that we can see you next time on the webinars. Bye for now.